For men with confirmed biochemical testosterone deficiency, accompanied by clinically significant symptoms that are not adequately addressed by lifestyle optimization alone, testosterone replacement therapy represents a well-established, extensively studied, and potentially transformative clinical intervention, one that deserves to be discussed with the same medical seriousness as any other hormone replacement in the context of clinically significant deficiency. The evidence base for testosterone replacement therapy in older men with documented hypogonadism includes multiple randomized controlled trials demonstrating improvements across the full spectrum of symptoms discussed in Section 3, including improvements in lean body mass and muscle strength, reductions in fat mass, particularly in the visceral compartment, improvements in bone mineral density, improvements in sexual function and libido, improvements in mood and energy, and improvements in insulin sensitivity and metabolic markers. The T trials, the testosterone trials, a coordinated set of 7 randomized placebo-controlled trials conducted across multiple academic medical centers and published between 2016 and 2018, represent the most rigorous and most comprehensive evidence base for testosterone replacement in older men with documented low testosterone. These trials demonstrated significant improvements in sexual activity and desire, physical function, bone mineral density, anemia, and mood and energy symptoms in men receiving testosterone replacement compared to placebo, with the magnitude of benefit substantially greater in men with more severely deficient baseline testosterone levels. Testosterone replacement is available in multiple formulations, each with distinct pharmacokinetic profiles, administration requirements, and practical considerations. Transdermal testosterone gels, applied daily to the skin of the shoulders, upper arms, or abdomen, represent the most commonly prescribed formulation in the United States, offering a convenient once-daily application that maintains relatively stable testosterone levels throughout the day. The primary practical concern with gel formulations is the risk of transdermal transfer to partners or children through skin contact, requiring specific precautions around washing application sites and covering them before close physical contact. Intramuscular testosterone injections, most commonly testosterone cypionate or testosterone enanthate, administered every 1 to 2 weeks by self-injection or by a healthcare provider, produce larger fluctuations in testosterone levels across the injection interval, with levels peaking in the days following injection and declining toward the lower end of the range before the subsequent injection. Some men experience symptom fluctuations that correlate with these level swings, feeling best in the days following injection, and experiencing return of some deficiency symptoms toward the end of the injection interval. More frequent injection at lower doses or the use of subcutaneous rather than intramuscular injection technique can substantially reduce these fluctuations. Subcutaneous testosterone pellets, small crystalline pellets implanted beneath the skin of the buttock or flank through a brief in-office procedure every 3 to 6 months, provide the most stable and sustained testosterone delivery of any available formulation, eliminating the daily adherence requirement of gels and the level fluctuations of injectable preparations, at the cost of an office procedure for each implantation and the absence of dose adjustability between implantation intervals. Oral testosterone, specifically testosterone undecanoate, is a formulation that bypasses the first-pass hepatic metabolism that limited earlier oral testosterone preparations, providing an oral option for men who prefer not to use transdermal or injectable preparations, though its variable absorption with meals and the requirement for twice-daily dosing with fat-containing food represent practical considerations. The clinical monitoring of men receiving testosterone replacement therapy is a non-negotiable component of responsible management, not a bureaucratic formality. Hematocrit, the proportion of red blood cells in the blood, must be monitored regularly throughout testosterone replacement because testosterone stimulates erythropoiesis and can drive hematocrit to levels associated with increased blood viscosity and thromboembolic risk if not identified and managed. Prostate-specific antigen should be monitored at regular intervals, not because testosterone causes prostate cancer, which the evidence does not support, but because testosterone stimulates prostate growth and may unmask pre-existing prostate malignancy that was previously below clinical detection. Testosterone levels should be measured at the appropriate time point for the specific formulation used, mid-cycle for injections, 2 to 4 hours after application for gels, to confirm that levels are within the therapeutic range and to guide dose adjustment. The single most important step that any man over 55 can take in addressing the possibility of testosterone deficiency is to have a direct, specific, and well-prepared conversation with a physician who is equipped to conduct a complete evaluation and to discuss the full range of management options. This conversation requires preparation because the time constraints of a standard primary care appointment rarely create the space for a comprehensive testosterone evaluation to emerge organically from a general health review. You need to bring the conversation to the appointment deliberately, specifically, and with enough clinical detail to signal that you are seeking a thorough evaluation rather than a brief acknowledgement. Come prepared to describe your symptoms specifically and chronologically. When did you first notice the fatigue? How has your muscle mass and body composition changed over the past 3 to 5 years? Have you noticed changes in your mood, motivation, or cognitive sharpness? How has your libido changed? Are you experiencing reduced exercise capacity? Do you wake refreshed or exhausted? Are you experiencing any vasomotor symptoms? Request specifically that the morning blood draw include total testosterone, sex hormone-binding globulin, free testosterone, luteinizing hormone, follicle-stimulating hormone, prolactin, thyroid-stimulating hormone, estradiol, complete blood count, comprehensive metabolic panel, fasting lipids, and hemoglobin A1C. Present this list in writing if necessary. These are all standard laboratory tests, available at any clinical laboratory, billable to standard insurance, and collectively providing the complete hormonal and metabolic picture required for appropriate clinical decision-making. Ask about specialist referral if needed. Endocrinologists and urologists with specific expertise in male hormonal health can provide the most complete evaluation and management of testosterone deficiency, particularly in cases where the hormonal picture is complex, where primary versus secondary hypogonadism must be definitively distinguished, or where testosterone replacement therapy is being considered and requires careful individualized optimization. Approach this conversation without embarrassment. Testosterone deficiency is a hormonal condition, no more personal or embarrassing than thyroid deficiency or adrenal insufficiency. It has specific biochemical causes, specific clinical consequences, and specific evidence-based treatments. It deserves to be discussed with the clinical directness that any other hormonal condition receives. No discussion of testosterone replacement therapy in men over 55 is complete without a direct, honest, and scientifically grounded address of the prostate health question, because this concern, often raised as the primary barrier to testosterone replacement, is more nuanced than the commonly expressed formulation suggests and deserves precise clarification. The historical concern that testosterone replacement increases the risk of developing prostate cancer was based primarily on two observations: the fact that prostate cancer is androgen sensitive and can be suppressed by androgen deprivation therapy, and the observation made by Charles Huggins in the 1940s that testosterone administration could stimulate the growth of pre-existing prostate cancer. What the historical concern did not adequately account for was the distinction between stimulating the growth of pre-existing prostate cancer and causing the de novo development of prostate cancer in men without pre-existing malignancy. The evidence from multiple large prospective studies and meta-analyses examining prostate cancer incidence in men receiving testosterone replacement therapy has been consistent and reassuring, demonstrating no significant increase in prostate cancer incidence in men receiving testosterone replacement therapy compared to untreated controls after appropriate pretreatment screening to exclude pre-existing prostate malignancy. The saturation model, the current scientific framework for understanding the relationship between testosterone and prostate growth, proposes that prostate androgen receptors become saturated at relatively low testosterone concentrations, above which further increases in testosterone produce no additional stimulation of prostate growth. This model predicts, consistently with the clinical evidence, that raising testosterone from deficient to normal levels does not produce the disproportionate prostate stimulation that raising it from normal to supraphysiological levels might. What the evidence does support, and what the prostate-related monitoring discussed in the previous section is designed to identify, is that testosterone replacement in men with undetected pre-existing prostate cancer can accelerate the growth of that pre-existing malignancy, and can occasionally unmask a previously subthreshold tumor that was not producing symptoms or sufficient PSA to trigger clinical evaluation before testosterone normalization. This is precisely why pre-treatment prostate-specific antigen measurement and clinical prostate assessment are required components of the evaluation before initiating testosterone replacement, not to prevent the initiation of clinically indicated therapy, but to ensure that the decision to initiate therapy is made in the context of a complete and current assessment of prostate status. Men with a history of treated prostate cancer represent a specific and more complex clinical scenario, one that is beyond the scope of this general discussion, and that requires individualized assessment by a urologist specializing in male hormonal management in the context of prostate cancer history. The comprehensive management of testosterone deficiency after 55 is most effective when understood as an integrated clinical program, one that addresses the lifestyle substrate on which the hormonal deficiency has developed, the biochemical hormonal deficiency itself when it meets clinical thresholds for treatment, and the full constellation of downstream consequences across all organ systems simultaneously. The lifestyle foundation, visceral fat reduction, resistance training, sleep optimization, stress management, nutritional optimization addressed first and consistently, both because these interventions independently improve testosterone production to a degree that may reduce or eliminate the need for exogenous replacement in some men, and because they provide the metabolic and physiological substrate in which testosterone replacement, when clinically indicated, produces its most robust and most durable benefits. Testosterone replacement, when indicated by confirmed biochemical deficiency with clinical symptoms not adequately managed by lifestyle optimization, implemented with appropriate pre-treatment evaluation, formulation selection individualized to the patient's practical circumstances and clinical profile, and consistent monitoring of clinical and laboratory response. Concurrent management of the downstream consequences of testosterone deficiency, metabolic syndrome, insulin resistance, bone density reduction, cardiovascular risk, through the targeted interventions discussed in our previous videos, now implemented in the context of a normalizing hormonal substrate that substantially improves their efficacy, and regular, ongoing clinical reassessment, recognizing that the hormonal and metabolic landscape of the aging male is not a static clinical picture, but a continuously evolving process requiring periodic reevaluation of both the hormonal status and the appropriateness of the management approach as clinical circumstances change over time. The hormonal transition of male aging is not a secret. The clinical consequences of testosterone deficiency are not obscure. The diagnostic tools required to identify it are not experimental. The treatment options available to address it are not new. What has been consistently missing from the majority of men's healthcare experience over 55 is not the science or the tools. It is the conversation. The direct, specific, clinically comprehensive conversation about the full constellation of testosterone deficiency symptoms, the fatigue, the muscle loss, the cognitive changes, the mood shifts, the metabolic deterioration, the cardiovascular consequences, and their connection to a specific, measurable, treatable hormonal change that is occurring in the bodies of the majority of men over 55. You now have the clinical knowledge to initiate that conversation yourself. You know the 13 symptoms to assess in your own clinical picture. You know the specific laboratory tests to request by name. You know the lifestyle interventions that address the hormonal substrate. You know the treatment options available when clinical intervention is indicated. You know the monitoring required to ensure safe and effective management. The next step is yours. Schedule the appointment. Draw the blood. Have the conversation you have been waiting for someone else to initiate. And that has been waiting for you to understand clearly enough to initiate yourself. Because the hormonal clarity that comes from a complete evaluation of your testosterone status is not merely information about a single hormone. It is a window into the integrated hormonal, metabolic, cardiovascular, neurological, and psychological health of your aging body, one that provides both the diagnostic understanding and the clinical roadmap for protecting and optimizing that health through the decades ahead. Your biology has been sending you signals. You now know how to read them. Subscribe to Dr. Core Health for weekly evidence-based health education for adults over 50 and 60. Share this video with the men in your life who need to hear this conversation, and I will see you in the next one.